now.
A very warm welcome to all. I am Shyam Akku, Head of Medical Marketing for Emerging Markets at Hetero. I welcome you all for today's session on optimal sequencing of Cabazitaxel in patients with metastatic prostate cancer, which is brought to you by Hetero in cooperation with the Philippine Society of Medical Oncology. It's a great honor to have Dr. Basciarello as the guest speaker for today's session and Dr. Ong Connell as the chairperson. The session will be followed by a Q&A session, and the delegates can post their questions in the chat box. I take this opportunity to introduce our chairperson for today, Dr. Ong Connell. So Dr. Ong Connell is a medical oncologist from Veterans Memorial Medical Center, Quezon City, Philippines. She's an assistant section chief medical oncology, Veterans Memorial Medical Center, Director of Cancer and Infusion Center, University of Perpetual Health, Delta Medical Center, and Head Chemotherapy Unit, Global Care Cancer Institute, Bay Laguna. So I invite Dr. Ong Connell to give a brief overview on prostate cancer in Philippines and begin today's session. Over to you, Doctor.
Thank you very much, Sham, for that generous introduction. So good morning, good afternoon, good evening, everybody who is able to attend this talk or lecture, since we're very much interested in the different types of treatment we can offer to our patients with prostate cancer. For the Philippines specifically, prostate cancer is the 5th leading cancer site in our country. It's the 3rd leading cause of death in terms of cancer for the male population. And for since last 2015, 6 out of 10 patients diagnosed with prostate cancer is roughly around 65 years or older. But unfortunately, lately we've been seeing them younger. So the idea of having more options of treatment or more options in our armamentarium for the treatment of prostate cancer is very important. So I'm sure that the concept of the entry of new medications is very much welcome for everybody here in this webinar. And without any further ado, Sham, I'd like to get the ball rolling and introduce our esteemed speaker. So Dr. Gilia, did I say it right? Gilia.
Julia, but you were...
Julia, okay. We're phonetic here in the Philippines. So Dr. Julia Basciarello is a medical oncologist from the Department of Medical Oncology at the S. Camillo Forlanini Hospital in Rome. She earned her medical degree and residency from La Sapienza University in Rome, following which she worked for 6 years at the Department of Medical Oncology at Gustave Roussy in France. Did I say it right, or do I have to... Okay,
Your
good.
French is perfect.
Dr. Basciarello specializes in genitourinary oncology with emphasis and focus on prostate and germ cell tumors. And we're lucky she's going to give us a talk because she has an extensive experience in clinical research and has served as a principal investigator and a member of steering committees in several clinical trials. So if as doctors have questions later with regards to prostate cancer and landmark clinical trials, then she's the best person to ask our questions. She is also a member of the EORTC GU Early Career Committee, ESMO faculty of the genitourinary tumors, and ESCO faculty. So Dr. Basciarello, you have the floor.
Thank you very much for your presentation, wonderful presentation, and thank you all the organizers for giving me the possibility to discuss with you the treatment sequences and the potential treatment sequences and prostate cancer in the CRPC setting. I think it's always very important and constructive to discuss the different treatments that we have in our different countries. So these are my disclosures. Well, we know that in the last 10, 13 years, we have assisted to a real revolution in the mCRPC management with docetaxel and the ARPI at the beginning and with cabazitaxel. And more recently, we also have the opportunity to use PARP inhibitors and lutetium PSMA. So we will see now in this 30 minutes which can be the optimal sequence with all these different treatments. I think that the most important thing to evaluate in our patients is that almost all of our patients develop bone metastasis in the mCRPC setting, and almost half of them will eventually develop skeletal related events. And these events included pathological fractures, the need of a radiotherapy or surgery to the bone, as well as spinal cord compression, which may have a huge effect on quality of life and healthcare system costs. But how many of our patients develop these events early in the disease? Well, we have different data, and this is just an example of a post-hoc analysis of patients included in the AFFIRM and PREVAIL trial, which evaluated the efficacy of enzalutamide in the pre and post docetaxel setting. And as you can see, even in the early phase of the mCRPC disease, almost 1/3 of patients developed skeletal related events. And in the right, you can clearly see that these events have a huge impact on quality of life, with a difference on the reduction in the quality of life score in the different questionnaires. That's why it's really important, and what I teach to my residents is that it's almost mandatory to use at the onset of the mCRPC setting bone protective agents such as biphosphonate or denosumab. We need to also to remember that we should perform an orthopanoramic test as well as a dental visit before starting these treatments because of the potential necrosis of the jaw, and start also supplementum of calcium and vitamin D because of the potential hypocalcemia. But what about the life-prolonging agents at first line? Well, we know we have docetaxel and abiraterone and enzalutamide that we usually use in our clinical practice, but we also have some data from Sipuleucel-T, which is a cancer vaccine, evaluated in the IMPACT trial in patients with minimally symptomatic or asymptomatic disease. And actually, this drug is approved also only by the FDA, and it showed an improvement in progression-free survival, in overall survival, but not in progression-free survival. And the radium-223 is a radioligand that delivers alpha particles. It is active only on bone metastasis, and it was evaluated in the ALSIMCA trial in patients previously treated with docetaxel or unfit or unwilling to receive docetaxel. Since it acts only on bone metastasis, it is used only in very selected patients. And we are waiting for the results from the P3 trials, trial that will evaluate the combination of radium-223 with enzalutamide in at first line in the mCRPC setting. So we usually use docetaxel or ARPI at first line, and in the absence of a clear direct comparison, actually it's up to the physician to choose the first line, considering different factors such as the performance status of the patients, the symptoms, the comorbidities, as well as the drug availability, the costs, and of course the patient's preference. So we can use docetaxel or ARPI at first line, but what we can use at second line? Well, we know now quite well that a sequence of an ARPI and a second ARPI should not be used. And we have lots of different retrospective data, and we have also already we know also different mechanism of resistance of ARPI that actually showed that this sequence doesn't work. And this is just an example of a prospective data of ARPI after an ARPI. These are the results from the Plateau trial, in which patients treated with patients were all treated with enzalutamide, and then at progression they were randomized to switch to abiraterone or continue enzalutamide plus abiraterone. So it was a combination versus second ARPI. And as the study was negative, there was no superiority in the combination compared to an ARPI alone. But what is interesting is that almost no patients had a PSA decline with the second ARPI, so with abiraterone after enzalutamide, and the PSA progression was evident at the first assessment. And what we also know from some retrospective data is that docetaxel is still active after an ARPI, and this is another example of a post-hoc analysis of docetaxel after abiraterone in the COO302 trial. And we know from the AFFIRM and COO301 trial that ARPI are also very active in patients already treated with docetaxel. So again, we need to switch the type of treatment in the second line after docetaxel and then ARPI, or the opposite sequence. But what we should use at third line, can we use a second ARPI at that point, or we should use another type of treatment such as cabazitaxel? Well, cabazitaxel is a taxane which inhibits which causes the microtubule stabilization, causing the stop of the mitosis and so the cancer cell death. It is it has an hepatic metabolism, so we do not need a dosage adjustment in patients with a renal impairment, but we need to be aware of the potential drug-to-drug interaction since it is metabolized by the CYP3A4 and CYP3A5. We should also avoid this drug in patients with a severe hepatic impairment, but we can use it with reduced dose in patients with a mild or intermediate hepatic impairment. We do not need a high steroid pre-medication irrespective of docetaxel. We should use steroids only in the during the day of the cabazitaxel, together with antiemetical protocol for low emetogenic chemotherapy and antihistamine. So the TROPIC trial was the pivotal trial who evaluate the efficacy of cabazitaxel after docetaxel, and it actually used an active comparator, which was the mitoxantrone, the standard of care at that moment. And the baseline characteristics were well balanced. Almost 25% of patients had visceral metastasis. And actually, it is very interesting to see that almost 30% of patients had a disease progression during docetaxel administration, while more than 40 patients had a progression less than 3 months from last dose of docetaxel. And this represents actually our clinical practice. So cabazitaxel was superior compared to mitoxantrone in terms of overall survival, with a reduction of 30% in the risk of death. And what is interesting is that cabazitaxel was superior in all the different subgroup analyses. So in patients who had a docetaxel resistance or who progressed early after the last dose of docetaxel. What about safety? Actually, 80% of the patients treated with cabazitaxel had a grade 3 or more of neutropenia, which means a neutrophil count of 1,000 or less, and 8% of these patients had a febrile neutropenia. That's why the use of primary prophylaxis with G-CSF is strongly recommended. For what concerns the other non-hematological toxicity, it was actually very well tolerated. Some of the patients had a mild diarrhea or experienced fatigue, but this was quite a highly pretreated population, especially in that period. We are speaking about 2010. In 2010, it became the standard of care after docetaxel. And the next question was, is cabazitaxel better than docetaxel? And the first STANA study wanted to evaluate and to answer these questions. Almost 1,200 of patients were randomized to receive docetaxel or cabazitaxel at 25 milligrams per square meter or 20 in a 1-to-1 ratio. Actually, cabazitaxel didn't show any superiority over docetaxel. But what is interesting is that we had a direct comparison of the different toxicity profile of these two drugs. In fact, they had quite a similar hematological toxicity, but docetaxel had most patients treated with docetaxel mostly have alopecia, peripheral neuropathy, nail disorder, and febrile neutropenia. And that's why, while we were awaiting the results from the first STANA, so we still didn't know which drug was superior to the other, that we started the phase 3B randomized trial. This was a patient preference between cabazitaxel and docetaxel at first line. So men whose disease progressed, men with a metastatic CRPC disease were randomized to receive 4 cycles of docetaxel, and in the absence of radiographic progression, 4 cycles of cabazitaxel, or the opposite. And patients were allowed to have received an ARPI. And at the end of the two periods, patients had to complete a preference questionnaires. The groups were well balanced, and actually, of the 106 patients who expressed a preference at the end of the two periods, 62% of patients preferred cabazitaxel versus 38% of patients of docetaxel. And on the right, you can see the most common factors that favored cabazitaxel, such as less fatigue, better quality of life, less hair loss, pain, less change in foot taxes, and nail deteriorations. And these are all very important for our patients in terms of quality of life. We have seen that in first STANA, there were 2 different dosage which were evaluated, 25 and 20. And the Proselica trial tried to compare the 2 dosage. Actually, as you can see, there was no difference in terms of overall survival with the 2 different dosage, but there was a clear reduction in the toxicity for what concern leukopenia, neutropenia, febrile neutropenia, as well as the other non-hematological toxicities such as diarrhea, fatigue, and GI toxicities. So that's why the recommended starting dose of cabazitaxel is 20 milligrams. So we had the question before that what to use at third line when we had already treated our patient with docetaxel and an ARPI. And the CAR trial tried to answer this question. It was a very pragmatic clinical trial, one of the most pragmatic that I have ever seen, at least in the GU cancer. Patients whose disease progressed after docetaxel and an ARPI with a response of 12 months or less were randomized to receive cabazitaxel or a second ARPI, and the primary endpoint was radiographic progression-free survival. there was a stratification factors of the timing of ARPI before or after docetaxel, but also to the time to progression to the first ARPI, 0, 6 versus 6, 12 months. And these are the different toxicity. What is quite surprisingly is that the number of the grade 3 or more adverse events were very similar between the two type of drugs. And it's surprisingly because we are comparing chemotherapy to hormone agents, and the other toxicity are what we know, and it was what we usually know about the adverse events of cabazitaxel and the ARPIs. So the CAR trial was clearly a positive study, and it showed a clear superiority in terms of progression-free survival, which was the primary endpoint, but also overall survival. The use of cabazitaxel versus an ARPI resulted in a risk of death of 35, in a reduction of the risk of death of about 35%, irrespective of the different sequence, docetaxel ARPI versus ARPI docetaxel, and the presence of visceral metastasis. So that's why cabazitaxel is the standard of care at third line, or at least one of the standard of care. The cabazitaxel was also superior in confirmed in PSA response, and most important in the objective tumor response per RECIST criteria and pain response. So we have seen that we should use cabazitaxel after docetaxel and ARPI, but we have now also PARP inhibitors and lutetium PSMA. So how to put them into our clinical practice? Well, we know that approximately 30% of our patients have HRR alterations, and since these alterations occur very early in the disease, we can easily use the primary tumor tissue, so the biopsy, the prostate biopsy, or the tissue from the prostatectomy, to detect these alterations. The most common are the BRCA2, which represent almost 1/3 of patients with an HRR alteration. What is also important is that some of our patients, about 5 to 10% of patients with a metastatic disease, have a germline BRCA mutation. And this is important not only for what concerns the prognosis of our patient, but also for the family. And we should remember that almost 40% of patients with a germline BRCA mutation do not have a family history. So who should be tested for germline BRCA mutation? Well, following the guidelines, actually we should test all the metastatic prostate cancer patients. However, I would like to underline the fact that we should not test, but we should propose the test. And that's because the patient needs to be aware of the potential consequence of knowing to have this mutation of all the family. So he should choose to have this test. And a profound study was the first one who evaluated the a PARP inhibitor, olaparib in this case, versus treatment by physician choice in patients whose disease progressed after at least one ARPI. And the prior use of docetaxel was also allowed. So practically the patients were, the olaparib was compared to a second ARPI. And especially in patients with a BRCA1, BRCA2, and ATM mutation, there was a clear benefit in terms of progression-free survival and overall survival, with a 60% reduction in the risk of death compared to the physician choice. While patients with the other HRR alterations seems not to benefit from PARP inhibitors. And more recently, in the TITAN-3 trial, rucaparib was tested against a physician choice in patients whose disease progressed after at least one ARPI. But what is very interesting is that docetaxel was allowed in the comparator arm, and the study was clearly positive. They included only patients with BRCA1, BRCA2, and ATM mutation, but he also answered two very important questions. Is the rucaparib and PARP inhibitors active also in patients with ATM mutation? And are PARP inhibitors better than taxanes? Well, the answer is yes for the taxane, but ATM patients seem not to benefit from rucaparib, as you can see by the progression-free survival curves, while BRCA, patients with a BRCA alteration had a clear benefit with a 50% in the risk, in the reduction of the risk of progression or death. Well, rucaparib was also superior to docetaxel in the BRCA subgroup, and it was the first drug ever to show superiority versus docetaxel in the prostate cancer setting. So we should test our patient as soon as possible for at least for BRCA mutations, but we have also seen that thanks to the VISION trial, that another option, at least at third line, is the use of lutetium PSMA, which is a radioligand therapy that delivers beta particles in cells expressing PSMA on the surface. And this was the pivotal trial in which patients with whose disease progressed after at least one ARPI and one taxane were, and with a PSMA positive PET, were randomized to receive lutetium or a standard of care. The study was clearly positive, an hazard ratio of 0.6 of lutetium compared to the standard of care. However, chemotherapy as well as radium-223 and immunotherapy were not permitted in this trial. So the standard of care was almost always supportive care or a second ARPI. And as you can see, less than 50% of patients had already received a second taxane, such as cabazitaxel. So we didn't have a real comparator in this trial. So is cabazitaxel, and these are the most common adverse events, mostly the lutetium is related mostly to a bone marrow suppression, which can be quite serious and prolonged, as well as dry mouth and GI toxicities. So should we use cabazitaxel lutetium instead of cabazitaxel at third line? Well, we don't have any real phase 3 direct comparison, but we have a small phase 2 randomized trial, which included only 200 patients, and the inclusion criteria was more restricted. In fact, patients had a high PSMA positive uptake, and they didn't have to discordance between the FDG PET positive and PSMA positive lesions. So lutetium had a clear, a better PSA response compared to cabazitaxel, and it was superior also in terms of progression-free survival, even if you can see that there is a clear cross, the curves are crossing in the first 6 months. And there was no difference in overall survival, even if the study was unpowered for detecting an overall survival gain. So lutetium PSMA is clearly a highly effective treatment. However, we need to consider several factors when proposing this to the patient, such as costs, logistics, availability, and also potential toxicities. That's why we need further research to better identify the patient that will benefit most from this drug. And we also know that the PSA decline of lutetium PSMA may be strictly related to a higher SUV, so a higher uptake of the lesions. And with patients with a lower uptake, the efficacy is clearly lower. So to conclude, the treatment landscape for metastatic castration-resistant prostate cancer is constantly changing. We are seeing now the early trials evaluating third-generation hormonal agents, for example, or lutetium PSMA combination, in early use of lutetium PSMA. We have now some results of a PARP inhibitors combination with ARPI at first line in the mCRPC setting. So while we await for the development of new drugs, I think that it is crucial to optimize the utilization of existing treatment by better tailoring these treatments to our patients. And with this, I thank you for your attention.
Thank you very much, Dr. Bacharello. So if there are questions from the floor, please feel free to post your questions so that we can ask Dr. Julia, correct? Dr. Julia. Anyway, to start the ball rolling, you did mention lutetium 177, correct? For prostate cancer with bone mets. So since it's a little bit pricey for most emerging markets or countries here in Southeast Asia or Southern Asia, can you comment on using cabazitaxel instead of lutetium 177 for this type of patients? Or is cabazitaxel really more for down the road third line option before thinking of it in terms of usage for this type of patients? And some of the patients really have used up your hormonal treatments already and probably even docetaxel. So we're sort of having to think what else to give to our patients.
Yeah, thank you. I think this is $1 million questions because we still don't have lots of data. Well, in my opinion, I think that we should select very, we should pay attention to the selection of patients that can benefit from lutetium PSMA, because it is really an active treatment, and I've been one of the investigator of the VISION trial. So I've seen the potential activity of this drug. However, we still don't know which kind of patients would benefit from this drug. And actually, there are some patients who progress quite early during this treatment, and they can have a clinical deterioration and not being able to receive a chemotherapy after progression. So what I can say is that for the vast majority of patients, cabazitaxel can be a very good option, especially in country like mine, for example, in which we have a very small availability of having a PSMA PET, which is of course mandatory before using lutetium PSMA. We will have the reimbursement of lutetium PSMA, I think, at the beginning of next year. But again, we have lots of problems of availability, and of course, we will be able to use it only in very selected cancer center, because we need a nuclear medicine department, of course, and the nuclear medicine laboratory, and the hospitalization also, some of the possibility to hospitalize these patients in the nuclear medicine department.
So it seems like in one of your trials comparing patient preference for docetaxel and cabazitaxel, the advantage of cabazitaxel is in terms of quality of life. The symptoms experienced by the patient, the treatment is better than docetaxel. How about were there any very prominent side effects from a hematologic point of view that, you'd really prefer cabazitaxel over docetaxel from a doctor point of view? Of course, from the patient, they prefer something which will have less side effects, less fatigue. They want to be functional. But from a doctor point of view, do we see less problems with cabazitaxel in terms of neutropenia, anemia, and increase in your liver enzymes or your kidney function?
Well, in my experience, actually, I use always primary prophylaxis with GCSF in both docetaxel and cabazitaxel, because I think that even if we don't have a very high percentage of febrile neutropenia, our patients are really frail. Some of them are have different comorbidities and are quite older patients. So I didn't see any difference for what concerned the neutropenia or febrile neutropenia. Of course, for what concern hematological toxicity, well, like anemia, for example, on thrombocytopenia, I didn't see any difference either. Probably there is a small proportion of patients treated with docetaxel who may develop thrombocytopenia, but it's quite rare, and it depends, of course, of the bone involvement in terms of metastasis and, of course, a bone marrow involvement. For what concerns the GI toxicity, probably there is a little bit less nausea with cabazitaxel compared to docetaxel, but this is again just my personal experience. But the two drugs have a very similar, honestly, GI toxicity, so diarrhea as well as nausea. For what concerns fatigue, of course, it depends on at what time of the disease you use one of the two drugs. I think that one of the most important difference are the alopecia, the peripheral neuropathy, which can be really an important point for what concerns quality of life. And I think that these are probably the most important thing that for which cabazitaxel can be better tolerated compared to docetaxel.
So is cabazitaxel really an easier drug to for the patient to take in?
Well, yes, it's easy. It's easy. I cannot say that it's easier, of course, but it's easy. And I remember when I was a resident in Rome, and cabazitaxel, and there were, I think it was 2011 or 2012, something in this way. And actually, we just had a reimbursement for cabazitaxel, but everybody was super afraid of use this kind of drugs because of the pivotal trial of with diarrhea and febrile neutropenia and so on. But actually, they didn't choose GCSF, and I had a 6 month period as a resident at Gustave Roussy at that point, and they widely used cabazitaxel because they were investigator of the TROPIC trial. And actually, I've seen with my eyes that there was no difference compared to docetaxel. That's why I took my experience when I was back in Rome. We started to use it quite easily, and we didn't see lots of toxicity. I think it's always quite a problem starting a new drug. We had the same things for immunotherapy, for example, in other solid tumors. So it's just questions of experience. What I suggest is to start at 20 milligrams for all patients, and sometimes I started also at 15 milligrams in very frail patients.
Yeah, I think the idea of starting at 15 or 20 is very useful for us Filipinos, since most of your trials will be on Caucasian, correct? Caucasian patients in terms of body surface area, and the way we handle neutropenia. Using it at 15 will be more practical for us, and probably somewhere down the road try to adjust the dose if the patient can manage. A lot of noise has been made about triple therapies, using your androgen inhibitors or docetaxel and your ADP. So how will this affect the positioning of cabazitaxel in your metastatic castrate-resistant prostate cancer? It seems like your medications are all moving up front, and the problem is when you reach your MCRPC, you have less weapons or armamentarium to use for your patients. So can you comment on this? Because this is a topic that's usually discussed now in a lot of conferences, this triple therapy for prostate cancer.
Yeah, I think that the triple therapy is highly active, especially in patients with a high volume disease, high burden disease. We still don't know who exactly are the patients who most benefit, because we are studying some prognostic and predictive factors. And we have an excellent meta-analysis that has been made by the Christine Sweeney groups and published this year for the triplet therapy, and I think last year for docetaxel doublet therapy, that actually showed that in patients with a high volume disease, the triplet therapy is the most active combination, while in the patient with a low volume disease, the doublet therapy with ARPI is more effective. So the triplet therapy has clearly showed an improvement in progression-free survival and overall survival in patients with a high...
Wait, charge ko lang to, baby. Halika, kuha tayo ng charges.
Okay.
Halika,
Can the
I'm
host
waiting for you here.
please mute? Okay, thank you.
We are using more and more triplet therapy in this kind of patients, and you are totally right. What we should do as the patients become mCRPC at that point, well, I think that the most important thing is to test for BRCA mutations, somatic BRCA alteration, because using PARP inhibitors or even carboplatin can be the treatment of choice at that point, at least for the patient with a BRCA alteration. And then we should clearly choose between cabazitaxel and lutetium PSMA at that point, considering all the different factors that we have seen before, especially the availability, the potential toxicity, and the comorbidities of our patients. But cabazitaxel still remains an active drug at that point. Of course, we don't have any data, but we have quite a lot of experience of using cabazitaxel right after a triplet therapy.
Before I move on to the question about BRCA and cabazitaxel, there's a question in the chat box. Going back to comparing cabazitaxel and docetaxel, the question is, do patients on cabazitaxel require more doses of filgrastim compared to docetaxel? I guess this is important since from a cost-effective point of view and numerous injections in the patient, and of course from the doctor point of view, they'd want to know if it's if you have less neutropenia with patients on cabazitaxel versus docetaxel.
Well, I don't think so. Actually, if you follow the guidelines, the international guidelines recommendation for the prophylaxis, you should use 5 to 7 injections for each administration for both docetaxel and cabazitaxel. Well, I think that PEG, GSSF are, of course, more useful a practice for the patients because it's just 1 injection. But I think that for most of the patients, 7 injections are really too much. So I usually start with 5, and we can reduce in docetaxel. If you see the different trial, for example, for Stana, that compared directly the 2 drugs, you don't have any difference in terms of neutropenia and febrile neutropenia. So the management of the prophylaxis should be the same.
Mm-hmm. And this is actually a significant question for us Asians, because from a docetaxel point of view for prostate CA, there were actually studies which showed that Asians actually have more febrile neutropenic episodes compared to the Caucasians. So I guess that was the reason why this question was asked on the floor. And then going back to the BRCA 1 and 2, as you've mentioned, we do have to test for BRCA upfront. And one of the problems, again, from our region is from a financial point of view, PARP inhibitors are a little bit more financially challenging. So would cabazitaxel have a position in this case? Like, for example, if the patients can't afford your PARP inhibitors and they've used up your abiraterone and your enzalutamide and your docetaxel, can you comment on this?
Yeah, sure. Well, again, I think that as early as possible, we should test our patient for BRCA alteration. And if a patient has a BRCA alteration, we should use carboplatin instead of PARP inhibitors in the absence of a availability of this, it's too expensive. And we have seen that carboplatin is really active in this kind of patients. We don't have, of course, a direct comparison of PARP inhibitor versus carboplatin, but honestly, we can use carboplatin in this kind of patients. And if you want, I can give you an example of a patient that I treated at Gustave Roussy in France, and actually he was included in the PEACE-1 trial. So he had a de novo metastatic hormone-sensitive disease, very aggressive. He had 42 years old at diagnosis, with a Gleason score of 9 and lots of bone metastasis. And he was included in the abiraterone docetaxel radiotherapy ADT arm. So he received everything. And after almost 1 year, he had a disease progression. So we had some phase 2 clinical trials in PARP inhibitors. So we decided to perform the test for HRR. But while we were waiting for the test, the patient started to rapidly deteriorate. The PSA was like 3,000 or something in this way. He had a performance status of almost 4. So I hospitalized the patients, and in the meanwhile, we received the BRCA2 test results, and he was positive. He had several liver impairment with AST and ALT of 2,000 and something like this, because he has lots of liver metastasis, and so he was dying. So I decided together with my chief, Karim Shizazi, we discussed a lot, and we discussed with the family, saying, okay, I'm trying to do a chemotherapy, but the patient can die in hours. Yeah. So we decided to start a micropediatric dosage of carboplatin, like AUC.
And the dose was AUC?
AUC2 with a reduction. So really just a drop of carboplatin. And after 3 or 4 days, he started to get better. And after 6 weeks, I think, he started to work again. He was a very important manager. And he was on carboplatin treatment for more than 1 year and a half. He started to traveling all around the world, and his liver mets disappeared. So actually, I can tell you with that actually it works, or at least it works very well in these patients.
And do you use carboplatin AUC2 weekly?
Well, it depends on the patients, because if they are really frail, such as this patient, we started with a weekly administration, but I usually prefer to a 3-week administration with an AUC 5 or 6 or 4, depending on the performance status.
And this was a monotherapy, carboplatin alone, because this is actually very useful in our aspects sometimes, because like you said, sometimes the patients are just too weak to undergo other treatment. And most of the time for metastatic castrate-resistant prostate cancer, they've used up all the available anti-hormonal treatment, like your abiraterone and enzalutamide. So it's a good thing that you actually have another option in terms of carboplatin for your this type of patients who are BRCA1 positive, correct?
1 or 2, yes.
How about if your patient is BRCA1 and ATM negative?
Well, I do not usually use carboplatin unless for some patients who develop mean a neuroendocrine transformation, which is happening more and more often because of the different treatments that our patients have. So in these patients, I can consider using carboplatin etoposide. But I think that it's important to rebiopsy the patients, for example, before using this type of drug.
We have another question from the floor. After docetaxel failure, which would you use, cabazitaxel or olaparib, for HRR mutation positive prostate cancer?
Well, again, I think that not all HRR mutations are the same. So I will not use, thanks to the results from the Triton 3 and also the results from Triton 2, I think, the combination of rucaparib plus enzalutamide. We have seen that all the other type of mutation probably are not sensitive to PARP inhibitors. So after in patients with a BRCA alteration, I will definitely use PARP inhibitors or carboplatin as soon as possible. So if the patient had already been treated with ARPI and docetaxel, right after, I will definitely use one of these drugs.
So are there any more questions from the floor? I think we've covered everything from triple therapy. What else can we give after that? We've covered the comparison of your docetaxel and cabazitaxel. We've covered the adverse events of cabazitaxel, the role of cabazitaxel in third line, and the role of cabazitaxel or other options like carboplatin for patients who are BRCA positive. So would you have any more? Oh, and of course, the dose of cabazitaxel that we can start at 15 and probably adjust to 20 and probably later on to 25. So would you have any important practical statements that you could help us with before we close the talk or end the talk?
Well, it's just that I think that, well, I lived in France, now in Italy, so I really see the difference, totally difference of treatments and the drug availability in the different countries. So in Italy, we have really less possibility compared to the other European countries. And I think it's important to know that we have different options, which can be cheaper or simple in our different countries. What I think also it's important is that we should, it's always, we are always afraid of testing new drugs and using new drugs in our clinical practice because we are, our patients are not the same as the ones included in clinical trials. But
that's true, because clinical trial patients are very super selective.
Yeah, that's why, you know, but honestly, what I suggest when we start to use a drug that we don't know is to monitor patients very often, even one time a week, in order to be sure that the patient is good. And to pay attention in the liver function, of course, for what concerns cabazitaxel, because it has an hepatic metabolism. And so to pay attention to this kind of potential toxicity and to, as when I use docetaxel, to inform the patients that they may have GI toxicity, especially diarrhea, that can be very even life-threatening for both docetaxel and cabazitaxel. So I think that the best way to start a new treatment for us, for the physicians, is to strictly monitor our patients at least for the first 1 or 2 cycles.
Okay, so if there are no more questions from the floor, we'd like to thank Dr. Julia, Dr. Julia, for sharing your experience and expertise with us. So may I turn over the floor to Shyam?
Yeah, thank you. And I'd like to thank Dr. Bastrello and Dr. Oncornell for an insightful discussion on the optimal sequencing of cabazitaxel in the patients with metastatic prostate cancer. It's been quite a journey that we've seen of cabazitaxel through various patient profiles and sequencing. Thank you once again. And to all the delegates who joined us for today's session. The therapy landscape of prostate cancer is evolving over the years and eventually improving the outcomes of patients. Hetero is at the forefront to make these affordable and available to the patients. And we have successfully brought the first generic of abiraterone and cabazitaxel to the patients of prostate cancer in Philippines, making it more accessible and giving these options to the patients. So we hope that all the delegates have found these sessions informative and transform these learnings to improve the patient care. Thank you. Thank you very much.
Thank you very much. Thank you again.
Thank you.
Thank you, everybody.